It's my great pleasure to kick off this event tonight by introducing Dr Melanie Davies, who's the chair of the Fertility Preservation UK, which is a special interest group of the British Fertility Society. She's a consultant obstetrician and gynaecologist at University College Hospital's Reproductive Medicine Unit and the Centre for Reproductive and Genetic Health. Melanie, over to you.
So I've been asked to talk about the challenges of fertility preservation for medical reasons, and that largely is for patients with a new cancer diagnosis, but not entirely. It will also include people with chronic conditions who are receiving gonadotoxic treatment, people now having stem cell transplants for a benign disease like sickle cell anemia, and people who are transitioning their gender. But what I'm not going to talk about is women storing eggs for their personal reasons, which is Sharon's subject that will follow. So, firstly, the facts. The UK numbers for women freezing eggs are quite difficult to get together. The HFEA collects data from the whole of the UK, and really we can get what I suppose you call a surrogate marker if you look at what is NHS funded, because that's going to be medical reasons. And this shows you the numbers over the last few years. This is the latest figures published. 200 or 300 NHS medical freezing cycles a year. Now, if you look at the cancer registry data, the number of women under 40 in reproductive years who have cancer is probably about 7,000 a year. Not all of them will have very toxic treatments, maybe less than half that number, but still, this is an order of magnitude away from the actual number of cycles being done. And that really illustrates the challenges of the process. I thought I'd illustrate them by telling you about 2 or 3 of my patients. This is a Renaissance picture that shows breast cancer, puckering, retraction of the nipple, and so on. That allows me to tell you about Amina, who was 34 and found a lump when she was breastfeeding her 6-month-old baby son. It didn't bother her. She didn't do anything about it for 2 or 3 months. And when she weaned the baby, she went to her GP. It was still there. The GP thought it was a blocked milk duct, but did refer her to hospital. The diagnosis of cancer was completely unexpected and was devastating for her. She was referred to an oncologist who said, "You're going to need chemotherapy. That should be your first line of treatment. It'll shrink the lump, then you can have surgery. Then we're going to give you radiotherapy, and because this is hormonal, you'll have hormonal treatment for the next 5 years." And it was only later on when she was talking to the specialist nurse that she said, "Does that mean I can't have another baby?" There was a panicked response. A few phone calls were made, and she was referred to the local IVF unit. They sent her some forms to fill in, which were a bit too much, really, so she took them to the appointment the next week. And I have to say, this is near me in central London. She was told at reception that, sorry, her freezing wouldn't be funded because she had a child. Why was she there? Well, the doctor saw her anyway, wasn't sure about the funding, but did an internal scan, did a blood test. She felt a bit pulled and pushed around, frankly. And after she got home and told her husband this terrible experience, she rang the breast nurse and said, "I'm just going to start my chemo on Monday." So I think that illustrates a few of the challenges that one is up against, and probably the biggest is awareness. Information not being given, referrals not being made when they could be. We did a survey of all the breast oncologists in the UK back in 2012 and found that actually it was the nurse who usually did the fertility discussion. And a lot of studies have echoed this one, which has been quite widely quoted. Oh, sorry, I don't think the pointer will work on that, but anyway. There was a real issue with oncologists feeling they didn't know enough to talk about fertility. They had constraints of time. There's a lot to talk about in oncology consultation. Rather worryingly, though, a minority agreed with the statement that fertility preservation didn't work well enough to discuss it with their patients. Certainly, patients with cancer feel that they're poorly informed. At the bottom of that slide is a recent survey of young people done by the Teenage Cancer Trust, and a significant number did not have a discussion, and those that did generally felt that it wasn't good enough. And then finally, about awareness, I've given you a quote here from a recent qualitative study where there were some in-depth interviews with health professionals. I think the fertility community is aware and on board. It's the oncology community that needs more work. A major obstacle is knowing what's available and where to send patients. Now, I think you may have conquered this north of the border, but in general, this is still a big problem, and I think it throws the challenge back at us, health professionals who are working in the field, to give that information. Also a bit England-centric, but in general, oncology services are not co-located with IVF. Patients have to travel. Fertility services aren't designed for cancer patients. They're designed for IVF patients who are often quite professional in their knowledge. And funding can be a maze. Delays can occur at every stage. Another problem that Amina had was information giving. She was overloaded. Just having the diagnosis of cancer really stops one's thought processes, and then the complexity of treatments and their side effects, and then these young women ricochet in through to see me a couple of days later in the fertility unit. We give them a crash course in IVF the same afternoon. So there's a lot of work done about information type, balanced information. This is something that may not work. It's not really an insurance policy. It may not pay out. Information timing, early as possible, and keep repeating it. And decision aids are quite a good solution. And I'm just going to show you this one, which is a website from Leeds Beckett University that's available freely online and can be very useful to direct patients to. I'm going to tell you about a couple of other patients. This was Sarah. She was an 18-year-old. I went out to call her from the waiting room. She was sitting with her parents. They were looking pretty glum. She was looking pretty unwell. Pale, listless, drooping in the chair. The referral letter was very brief, and she just said, "I'm here to freeze my eggs." But the parents told me how she'd been unwell for weeks with fevers, cough, breathlessness. She couldn't even lie flat. She'd gone to the GP, and eventually a chest X-ray had shown a big mass in the chest. And without getting too technical, this was a mass of lymph nodes that was pressing on the airways and on the big blood vessels. She wasn't fit for an anesthetic. So their expectations had been raised that this was an outpatient procedure. She could just come in that morning and freeze her eggs. And that is quite hard to unravel. So as I say, the challenge that leads to discussing is the one that I face as a doctor, that of safety. And that's where I feel on the safest ground, actually, myself, because I can get a grasp of this. Some patients are too unwell to recommend they go through these procedures. And even fit patients can get complications. Ovarian hyperstimulation, well, you can minimize the risk, you can't get rid of it. And if you end up in hospital with hyperstimulation, your chemotherapy may be delayed. That probably takes me into the ethical issues, because if one does fertility preservation for everybody, not only will some people have complications, but there will be some repercussions down the line. I'm not going to give you a case here, but I've seen 3 people in the last year who came with their partners asking to freeze embryos, although they had a poor prognosis, so that the partner could use them after death. And that, of course, does raise a lot of issues, because as health professionals, we are bound to consider the welfare of the child, as it's often called, WOC, which is technical speak, but a very important consideration. And what could be harder for a young child but to grow up with a parent seriously ill and watch them die? It doesn't mean we don't do the freezing, but certainly we need to think about it. And then the final patient I wanted to tell you about is Kami. He was a gangly 15-year-old when he was sent down to our laboratory, feeling absolutely dreadful. He was in a wheelchair. The week before he'd been playing football, but he had acute leukemia. He was shown into our best production room, but it is a bit like going into a bathroom with fluorescent lighting, plastic chair, and a table with some pornographic magazines. Anyway, even with his mum outside in the waiting room, he did manage to produce a sample that we froze. He had pretty grueling treatment. He had a stem cell transplant with total body irradiation. But he made a full recovery. He's now mid-20s. I hope he's enjoying his life. He may come back to us in the future when he has a steady relationship, but he'll never be a father. That treatment has more than a 95% chance of sterility, and his samples have been thrown away. And that's the last challenge I'm going to leave you with, a regulatory one. We can only store samples when we have effective consent. And when Kami was 15 and came into the lab, he signed a 10-year storage. Our staff felt we were doing the right thing at the time. We haven't been able to contact him. We even got in touch through his original haematologist, and their nurses contacted him. So he has been spoken to over the phone. An appointment was made for him to come in for a late effects review and for an analysis and to re-sign, but he didn't attend. The 10 years came up. Not only does the regulatory consequence have implications for the health professional, but there are 3,000 other men who rely on us to look after their samples, and we couldn't take that risk. So I hope that will spark some discussion. Thank you for listening.